righty, if we could all sit down, we're going to start the afternoon session. My name is John Golan, and I spoke to you earlier today, and have a couple talks later this afternoon. We're going to have a little change in the order. Dr. Sharifi, who's an interventional cardiologist from Arizona, is going to speak to us about the torpedo trial.
Good afternoon, everybody. My name is Mohsen Sharifi. Thank you, Dr. Golan, Dr. Thor, for the invitation. We're going to start with the torpedo trial. By the way, torpedo stands for thrombus obliteration by rapid percutaneous endovenous intervention in deep venous occlusion. This study started recruiting patients from 2007 to 2009. So now we have a somewhat different approach to what we used to do at that time because we've learned more. But the take-home message is simple, that percutaneous endovenous intervention, it does reduce recurrent venous thromboembolic disease and post-thrombotic syndrome. Now, one should recognize that even if you have appropriate anticoagulation, over 21% of those patients go on to develop PE. And if there's a proximal DVT, about 50% of the patients may develop post-thrombotic syndrome. This is at a very high cost of around $1.5 billion annually. Now, the current management of venous thromboembolic disease that we have, according to the guidelines, I believe is going to change in light of new data. But that stands for 5 days of parenteral anticoagulation, vitamin K antagonist, and 1 day of therapeutic overlap. If you look at the ACCP 2008 guidelines, they actually went on to say that for the first time, that percutaneous endovenous intervention in different modalities is helpful in select cases. And they even went on to differentiate when to use catheter-directed thrombolysis versus pharmacomechanical intervention. But in 2012, they retracted all of what they have said, chiefly because all those individuals who were in the trenches doing these things were not allowed to vote. And they went back to the slide I showed you. However, the Society for Vascular Surgery echoes the 2008 recommendation, as does Society for Interventional Radiology. Now, the torpedo trial was a randomized single-center prospective trial in patients with acute symptomatic DVT. This is an example of the patient who was enrolled. You can appreciate the right leg being swollen, edematous, indurated, and so forth. There were a total of 183 patients randomized, 91 to the interventional group or the PEVI group, and 92 to the control. 8 patients subsequently could not be left alone because they were doing so poorly, but they were not included in the analysis, and the follow-up was at 30 months. The primary endpoints were post-thrombotic syndrome and recurrent venous thromboembolic disease. We used this definition for post-thrombotic syndrome. We did not use the Vialta score, but as you can appreciate, anything in the Vialta score is here. This is an example of mild form of PTS. You have edema and in the presence of new onset of reflux. This is an example of moderate PTS, presence of symptoms plus skin changes. And this is the example of the severe form. Now, I want to draw your attention here. This kind of venous pathology I don't see in my patient population. But that said, the secondary endpoints were skin induration, leg edema, hospital stay, and subjective perception of improvement and bleeding. If you look here, the average age was around 60. The rule of 20 applies here. In other words, 20% of the patients had previous VTE, another 20% had concomitant pulmonary embolism, and another 20% DVT at another site. The control group received the standard anticoagulation. This is the coagulation that's still recommended, although we have refined our approach. And those in the interventional group went on to receive PEVI, percutaneous endovenous intervention, within 24 hours. At that time, we placed IBC filter in everybody. We don't do that anymore. And also, one should recognize that they received aspirin as well for 6 months. This was ultrasound guided. Micropuncture needle was used. The popliteal approach was utilized. The PEVI modalities consisted of angiojet, trellis, balloon venoplasty, stenting, catheter-directed thrombolysis, and manual aspiration. This is an example of some of the clots extracted. And I'd like you to draw your attention to his evil face. These are the eyes, and this is the teeth, and really bad-looking clot. And these are some other examples. Again, there is a spectrum of veno-occlusive disease in DVT. On one side of the spectrum is the acute thrombus with preserved venous anatomy. Contrast that with distorted venous anatomy and venous architecture, and this has significant clinical implications. This is an example of the left side of this spectrum. Can we run this, please? I promise you, we went over this and it was flowing smoothly. But for some reason, we can't have this run. At any rate, what I want to...
Can you all in the back make that play? No?
Okay, well, we lose a lot of interesting data here. I just have to go forward. But at any rate, what my point was that in one side of the spectrum, you have distorted veins. You can't see the architecture well, and that poorly responds to thrombolysis. And no matter how much thrombolysis you give, it's not going to take care of the problem. And the venous conduit has to be placed in the form of stents. And here we have Viabond stents in the femoral vein. Unfortunately, it doesn't show the flow. Now, the response is nearly almost instantaneous. This is a patient who presents initially, and then you can appreciate the change noted in a matter of hours. This is the outcome data. At 30 months and at 6 months, we reported them separately. At 30 months, recurrent venous thromboembolic disease was 4.5% in the PEVI group versus 16% in the control group, and post-thrombotic syndrome, 7% versus 30%. And these were statistically significant. Also, the secondary endpoints of bleeding, hospital stay, edema reduction, skin induration, and subjective perception of improvement were all in favor of intervention. What about aspirin? This is before the Warfasa and Aspire trial came out. In that trial, in the Torpedo trial, we recognized that in those patients who developed PTS, in the control group, a minority of them were on aspirin, whereas for those who did not have PTS, the majority of them had aspirin. And that imparts a 37% risk reduction in favor of being on aspirin. These are the Kaplan-Meier curves for both recurrent VTE and for post-thrombotic syndrome. The curves diverge initially, and then they maintain their benefit at 30 months. The approach is really not that difficult. You need a micropuncture needle, an ultrasound probe. This is the setup, if it is unilateral, if it is bilateral. And at the end of the procedure, we remove the sheets. The patient is made ambulatory an hour later, and this is very important. And then they go home nowadays in less than 2 days. So my personal approach, we use the popliteal access. Irrespective of the patient's anticoagulation status, you can intervene in the venous circulation. Through the side port, you give the anticoagulant, which is now we use unfractionated heparin because we get these patients out of the hospital fairly soon. You modify the dose of heparin. You remove the sheets if you're giving catheter-directed thrombolysis after 24 hours. Beyond 24 hours, you're asking for complications. Nowadays, we use new oral anticoagulants. We don't use Coumadin anymore. Even if the patient can't afford it, we give them some free samples, send them home, and then deal with this later. So the hospitalization time has come down to less than 2 days. So in conclusion, percutaneous endovenous intervention is superior to anticoagulation alone. It reduces recurrent VTE, PTS, and hospital stay. Whatever you do, you want to say no to clots. Thank you.
Dr. Ossie. Here he is. So he's going to speak to us now about what happens if you decide not to treat your patients with thrombolysis and the natural history of acute DVT, the venous pathology.
Actually, I was crying in my room because of the game, so that's why I'm late. Thank you again. So, my next presentation is about one question that Dr. Patricia gave to me is, what happens to veins after DVT, after deep venous thrombosis? And when we were discussing this problem, I decided that the best way of discussing this was to transfer that to this. When one patient comes to our office with deep venous thrombosis and they ask us, please doctor, what's going to happen to my veins after my deep venous thrombosis? And what do we respond? What kind of answer do we give to those patients? And what we know is that after DVT, we do have structural and functional damages to those veins that will lead to something that we call post-thrombotic syndrome. And one reason for that is because the clots will destroy one of the most delicate and beautiful structures, anatomic structures that we have in our body, that are the venous valves. So what happens? What we know is that post-thrombotic syndrome will come because of the deep vein obstruction, the development of venous reflux, and calf muscle pump dysfunction. But how does it happen? After a thrombus formation, a clot formation into any vein of our body, what we do have is, if you have any kind of recanalization or clot lysis, you have to look after the valve damage that will develop, and after a valve damage, the extent of reflux that will appear, and that leading to an increase of venous pressure, and then you have the signs and symptoms of post-thrombotic syndrome. But when we are thinking about this and looking to our patients, there's a lot of different things that goes through our minds to answer that question. And this slide will try to discuss that. So after DVT, you have to think about the location of the clot formation and the propagation of that clot. Even if you get started and treat this patient with heparin, some of the locations will, propagate with a lot more clot formation and propagate the extent of DVT. And after this DVT and the propagation, when you start treating, what is going to happen? Are you going to have some extent of recanalization? Is this recanalization to be total, so you have an entire occluded vein that will recanalize the entire segment? It will be partial, so one part of that clot, that DVT, will stay there. And if you have total or partial damage, recanalization, still, do you have valve damage that will lead to reflux? Or is it, after treating this patient and even treating this patient, do you still have some kind of obstruction? And this obstruction will be in just one segment, multi-segmental, or are you going to have, in some patients, rethrombosis that will, bring this patient back to a worse situation? All this is related to risks of rethrombosis that we know that are there in some patients, like thrombophilia, blood type, that we have seen that patients with blood type A positive are in a worse risk of rethrombosis, or is he exposed to another trauma, another surgery that leads to an increased risk of rethrombosis. And rethrombosis, we know that will lead to a worse situation for post-thrombotic syndrome. And this slide shows us that when you have patients with rethrombosis, the extent of reflux will be worse in the segments of femoral popliteal veins. So these are the patients that will develop the most severe cases of post-thrombotic syndrome. Propagation of the clots is also a major problem that will shows us the kind of patient that will develop the worst cases of post-thrombotic syndrome. So what I'm trying to say is that if you want to treat this patient and avoid the development of severe cases of post-thrombotic syndrome, you have to stop the extension, the propagation of the clot, and to see where the clot is inflammation to treat before they get obstructed. So, I'm sorry. So, of course, when you get a patient with acute DVT and you treat with endovascular techniques and you do lysis and you recover the vein just like that, and you save the valves and you save the axial conduit, you know that it's less probably that this patient will develop post-thrombotic syndrome in worst cases. What we do know is that sometimes we decide to not do anything, to not do any endovascular procedure and leave the body to develop collaterals, and the patient will be fine for the next years. But what we see later is that even those collaterals will turn into a problem, will turn into varicose veins, and those patients will also develop post-thrombotic syndrome and the signs of symptoms of bad disease. So this is what we don't want to see happening to our patients. And when that patient asks us what to do and what's going to happen to our veins, to their veins after DVT, what I tell them is, my dear, if you have an acute DVT, whatever they are, just go to your doctor and think about doing endovascular procedures and recover that vein as soon as possible. Thank you.
All right. So, Dr. Ossie, if you continue to have psychological stress over your soccer loss, they have a very good bar up in the Palm Restaurant where you can seek therapy. All right. Next, Dr. Zeiler is going to come back and talk to us about what a proper pre-treatment venous exam consists of and how to do it.
Get our names straight up there. Thank you very much. Nice to be back up here. And as I was thinking about the title I was given, I was wondering if somebody was afraid that I was going to start talking about an improper preoperative venous ultrasound. But I guess that's just for emphasis. Before you do any venous intervention, you're probably going to do a variety of tests, and you're going to want to know about obstruction and reflux, which we talked about this morning. So I thought I would just focus on a couple of areas that pertain directly to preoperative issues or preoperative planning. And these are things that you might do yourself if you're the treating physician, or that you might have your sonographers do. And those are vein mapping and then assessment of veins for superficial vein ablation and sclerotherapy. So what about vein mapping? Well, the rationale, I think, is fairly straightforward. In spite of the fact that we're using more and more endovascular techniques for lower extremity revascularization, vein grafts still play an important role, at least for vascular surgeons. And preoperative vein mapping is really a key step in planning operative technique. Because we have a variety of options. Obviously, for many years we've done reversed vein grafts, in situ vein grafts, and occasionally resorted to what I refer to as alternative veins, which is really anything except the great saphenous vein, and often this involves arm veins, which personally I hate arm veins, but sometimes we have to use them. And I only say that because they're difficult to dissect out, or they're rather tedious to dissect out, and they often have a lot of branches, and they're often very scarred. So they present their own challenges. But when we do this, then we can really plan how to use the best vein that's available and how to plan our incisions so that we don't have or minimize the chances of wound complications and things like that. So the features that are important are the diameter, the quality, the length, the presence or absence of branches and anatomic anomalies. We really go for the great saphenous vein first if it's available, then the small saphenous vein if that's an option, and then lastly the arm veins. For lower extremity bypass grafts, diameter is very important. The minimum diameter that we usually look for is 2 millimeters, but larger is better. And this really depends on what we're going to use it for. For vascular access, which is really another issue, 2 millimeters would be a little bit on the small side. If the distal saphenous vein is 2 millimeters and I'm going to do an in situ graft, I think that's probably okay, but if we want to do a reverse graft, that may be problematic. The quality refers to wall thickening and scarring, and of course length depends on the planned procedure, and occasionally we do have to use multiple vein segments. And we generally mark all the veins that we're going to use so that we can plan our incisions. The technique is pretty straightforward. A high-frequency scan head is helpful. We find that warming the patient with warm blankets or towels really does help. For the lower extremity, putting the patient in foot-down position. Tourniquets I put plus minus. We don't use a lot of tourniquets. We haven't found them to be terribly helpful, although some labs like them. So we basically have the sonographer make a little sketch with diameters and other notes about sclerotic segments, location relative to the fascia, patency and occlusion, and this is one area where I think a diagram really helps. Some examples. On the left there, just measuring a cephalic vein diameter, and both in transverse and longitudinal views. Example of phlebosclerosis, or just a little calcification and scarring in the great saphenous vein, shows up as an echogenic area within the vein. And the color flow is helpful, as shown there in the upper right, to show wall thickening. And you can use compression and the other same maneuvers that you use with for DVT. Quite often we find what we sometimes refer to as duplicate or accessory saphenous veins, particularly in the thigh. And sometimes these branches can be very helpful, particularly if you don't need a lot of vein. And the relationship to the fascia is also important for dissecting these things out. And we generally mark them right on the skin, as shown here. So this is generally best done close to the time of surgery. If it has to be done far in advance, sometimes we actually give the patient a Sharpie marker to take home with them so that they can reinforce the marks if they start to fade, but we try to avoid that. As far as vein ablation goes, the catheter-based ablation techniques require a little bit more detailed preoperative assessment than the old stripping techniques. Because there are a number of considerations that pertain directly to the technique. Usually sclerotherapy or some other techniques used for the branches, but preoperative imaging is really a key step in planning the procedure. So again, we use a sketch that provides a roadmap, and particularly looking for all the sources of incompetence, because really when you're treating chronic venous insufficiency, you're getting rid of the branches and the main trunk for somewhat for cosmetic reasons, but what you really want to do is make sure that you get that you're aware of all the sources of reflux, so that maximizes the outcome and minimizes the chance of recurrence. In patients with groin, medial thigh, and posterior thigh varicosities, a non-saphenous source of reflux is highly likely, particularly a pelvic source of reflux, and I'm sure that'll be discussed by others throughout this meeting. But the pattern is seen particularly in female patients during or after pregnancy. So the preoperative venous ultrasound for vein ablation is similar to vein mapping, but I consider it a little bit more detailed because in addition to the size of the veins and the location, you're interested in the depth and the presence or absence of reflux. And this pertains to technique, what sort of the kind of anesthesia that you might use and the use of tumescent anesthesia and certain risks that go along with thermal ablation and need for other treatment. And I think we'll talk about perforating veins tomorrow. So our sonographers are accustomed to making these very, very detailed diagrams for us prior to venous interventions. We may not do this at the initial evaluation, but when the patient is being specifically evaluated for intervention, that's when this occurs. There are a bunch of treatment decisions that can be made based on the ultrasound parameters. I already mentioned making sure that all sources of reflux are accounted for. And there are a variety of contraindications to ablation. And these vary a little bit by technique, but one version is summarized here. If the veins are too small or too large, that may be a factor. If there's obstruction in the veins or tortuosity, that's important. If the veins are immediately under the skin, that's potentially dangerous as far as burns, and that would require an alteration in technique in some cases. A very dilated saphenofemoral junction may be problematic. And if there's extensive deep venous obstruction, you may think twice about obliterating a lot of the superficial veins, as Tom Rook alluded to. So in summary, a proper preoperative venous ultrasound is very helpful in a variety of settings. Vein mapping improves vein utilization and minimizes wound complications for open surgical procedures that require vein conduit. And then for planning of vein ablations and sclerotherapy, this is really the only way to locate all sources of reflux to make sure that there are no contraindications or features that would require modification of the technique, and certainly it's a way to improve outcomes. So there's your proper preoperative venous exam. Thank you.
Patty? Can you turn this microphone on in front?
I understand that Dr. Sharifi, they have your videos properly working now. Would you like to show that, or would you like to?
Do you want to finish at the end of the session? I can do that.
Then the live case thing.
It's your turn.
I wanted to just say that I had introduced this patient before. She's the 48-year-old woman with a chronic pain and post-thrombotic syndrome. And even though this case was recorded for ICON 5 years ago, we still have the same protocol, the same procedures, the same results. So hopefully it will be helpful to those of you who are starting to embark on some of the more difficult cases that are chronic or acute on top of chronic. So this is a live case recorded in February of 2009 for that 48-year-old woman. Thank you. Thank you. I know it's slow to watch these vein cases, but I want to just reiterate something that we've learned over the years, that you obey the laws of surgery where you bypass. You bypass from good flow to good flow, and the same with stents. You must put stents in from good inflow to good outflow. And so if the femoral vein looks a little ratty, but it works, and the contrast clears through there, and you're not artificially filling it with contrast, you're allowing the inflow to take it out through the stent, then a ratty-looking vein that works well is better than a stented vein that doesn't stay open. And I've learned that from experience. So the bottom line is that we usually do stent to the inner trochanter, and we really try hard to get good inflow, because just as you would never put an aortobifemoral bypass in a patient that didn't have any runoff, we don't like to stent anyone who doesn't have any inflow coming from their deep system, from the popliteal up through the femoral vein. So I know it probably raises lots of questions, but I think we'll go on with the other talks, and anybody can ask questions at the session. Thank you.
Thank you very much. That was a fascinating case. Was that pretty much done in real time, or it's amazing how quickly you were able to do all of that. So next on the docket, Dr. Ossie is going to come up and talk to us about the present and future of venous valves.
Thank you again for your attention. Well, after this presentation of this interesting case of Dr. Patricia, I think we get started saying that when we treat those patients with chronic obstructions, the one thing that people keep asking me wherever I go is, so you treat those patients and then you treat the obstruction, but you give reflux to them. So what happens? Do they get better? Do they improve with their post-thrombotic symptoms? And what happens? And this is one of the reasons that many years ago, Dr. Patricia and I decided to get started and go after something that would answer that question. Because what we do know is that, for real, we do treat the obstruction, but we do give to those patients a conduit that doesn't have a valve, so they will have some extent of reflux. But what we do also see is that their quality of life will improve a lot, so they get much better than they were before. But still, we do have to find something to give to those patients to treat reflux. And we have seen in the last years a raise in the interest of people about the venous procedures, about venous interventions, and how to treat those patients. But we still don't have an answer to that problem, the valve problem, how to replace damaged valves that were destroyed after clot formation. So in a normal person, what we see is that those valves will close down and prevent reflux. And what we do see in other patients with primary reflux is that some of them will not show a single valve, and they will have signs and symptoms of chronic insufficiency, venous insufficiency, that is close to what we see with the patients after deep venous thrombosis and a post-thrombotic syndrome. So we have to find a way of treat them and replacing those valves. So what we do now, what we have been doing these years, is to treat the clot, do angioplasty in scarred veins, and implant those stents that will give a new conduit, a new axial conduit to the venous flow. But we still don't have anything that will replace those valves and prevent reflux. So the idea for the last 15 years that we've been working to find that answer is to treat the clot, treat the thrombose, and by means of a catheter to implant a stent that has a valve mounted onto it. And then one of those stents will prevent reflux. So we do now have a lot of new technology that treat the clot, treat the deep venous thrombosis, but we still don't have the valve stent. So what I'm going to show you is what we have been doing when other people have been doing all these years, trying to find this new valve to replace the one that were damaged after DVT. So this is what we have. You have an occluded vein, you do lysis, you do angioplasty, you implant a stent, you have a new way of blood flow going through the axial veins, but you still have reflux. So we need something just like that, a valve working, opening and shutting down and preventing reflux. So this is history. The very first idea was to use human sclera as a valve replacement. So this is how we did. We cut down the sclera and tried to build a valve on a stent structure. But what we found out is that this is economically impossible to do, so we moved to the next generation using a new structure. It's called SIS. It's actually submucosa of pig's intestine. And we did implant in pigs, and what we did have as an answer is that after a few months, those valves are destroyed and absorbed, so it didn't work. And this is another idea of a valve stent that you take an axillary valve and put into a mount into a stent, and then you implant that, but it's too thick and it doesn't work, it closes down. And this is the square stent, the closest that they could get to a functional valve using the SIS, and they did implant in humans, but had this kind of response, the thickening of the valve, so it doesn't work well anymore. And this is another design from another company that tried to replace the valve and the bulb, but didn't work. So we went back to the design, the natural design of the valve, that you have the pocket and the bulb, and the bulb is important in order to put a lot more blood volume into the pocket and close the valve and then make it work well. So we did design something close to that bulb and try to use it. But the problem, and we still have the same problem to find the best valve material to implant and not have it thrombosed or destroyed by the venous wall. We did find a new material that we are trying right now. It's under observation, under tests in animals. And what we also found is that the number of struts that you use to fix that valve into the vein wall is important in order to prevent inflammatory response from the vein. So this is the new design that we are developing, the new valve that has that material that is called member cell. And as you can see, there are only 4 struts and the guide wire, and this material that is dry, it's a bio component, and we are now trying to implant those in animals to see what happens. And it's also replacing, the bulb design, as you can see, that will give the chance, the opportunity for those pockets to open and close down just the way they do in the natural, as the natural valve. So this is one implant that we did in a dog, that you can see that the valve stand into the vein, in the vein. And then when you do the process of taking out the blood and see what happens, you can see that the valve closes down and prevent reflux. So the idea is to use that valve in between two stents that you use to recanalize a segment of occluded veins, and then you treat the obstruction and you also treat reflux. This is where we are. So the idea is that in the future we do need to find a way of treating the occluded vein and also treat reflux by replacing the valves with one of those devices. Thank you.
Thank you very much. There is a fairly extensive literature on trying to transplant valves from the arm veins to the legs, but the ability to do this percutaneously would really be fantastic. Next, Dr. Martinez Trebell, who's a vascular surgeon who comes from Puerto Rico, is going to talk to us about challenging cases related to DVT and pulmonary emboli.
So I think we are all clear with regards of clearing the veins and putting them together so we can reestablish the flow. There's a thing that I need to press when we're taking out the clot. I think that the inflammatory response on those valves make them sclerotic and they retract. And that's one of the problems. And the other thing is just a comment from previous presentations that it's the veins with the thrombus, they sclerose and they lose the capacity of being a capacitance vessel. So it's like when putting yourself in the water and breathing through a straw. If you're calm, it's okay, but the minute you get stressed out, you can't breathe through that straw anymore. So that's how they develop, venous claudication, etc. So I ask everybody, if you have an opinion on this case, please come up and say it, because Dr. Golzar asked me to put a case that hopefully you will come up and say something about it. So this 45-year-old female came up to, she comes into the hospital with the vaginal bleeding, and she had a symptomatic anemia, she had a hemoglobin of 5, and she was lightheaded, and this was her second episode. So she goes to the hospital, has hypertension and diabetes, and on her third day of admission, she's in bed, and she's been transfused. She develops a iliofemoral DVT. So during the initial admission, which was at a different hospital, on day number 7, they put an IVC filter, they take her to the operating room, they do a DNC, perform biopsies, and then they send her home with a left iliofemoral DVT. So, what would you expect? You have a patient with a proximal DVT, a big swollen leg. So what she did at home was not much, because she was having a lot of pain in the leg, with an IVC filter further up in the vena cava. So day number 39 from her initial presentation, now she's swollen from the waist down. She can't walk. She's still having episodes of bleeding, vaginal bleeding, and she goes to the hospital. Once again, her hemoglobin is 7, and they don't know what to do with that lady. So they send her to a different hospital. From there, she gets discharged again. They told her they can't do anything. Eventually, on her third admission, they call me. I receive her in my service. So now what do? We have a lady that had a left iliofemoral DVT a month and a half ago. Now, just on her clinical scenario, her IVC is thrombosed, most likely way above the filter or just at the filter, and she's still having vaginal bleeding. Any recommendations? Somebody from the audience? Anybody here?
Yeah, actually, vaginal bleeding is not a contraindication to low-dose thrombolysis. So you can bring this patient in, put 2 catheters into each leg, and start dripping very low dose and a modified TP and a modified dose of heparin.
Well, you know, that's a good option. I know some people there will be thinking, well, why don't we do pharmacomechanical, right? And what about the pathology in her uterus? You know, so we decided to find out what was the pathology, and they didn't have a real diagnosis. It was called an inflammatory endometrium and some blood, so we didn't have on CT scan, she has some tumor there, but we don't know what it is, right? So this is what I decided to do, okay? First, I gave her anticoagulation and transfuse her to a normal hemoglobin. Then I talked to the GYN doc to take her to the operating room and do a hysterectomy. Okay, so that was my approach at that time. And so after the hysterectomy was performed, we resumed anticoagulation therapy, and I took her to the operating room. So, you know, throughout this process, she was on stockings. We did some physical therapy to see if we could help her move around. And so I took her to the operating room from her admission, it was about 10 days. So we had the left side is about 55 days old, and the right side was about 14 days old. So what I did a hybrid thrombectomy, which is a simple incision in the groin, and you can see all the thrombus in the vena cava, you know, occluding the filter, and there's not much thrombus in the common femoral, but you can see there's an area of, I'm sorry. So I did the thrombectomy. I pulled as much thrombus out as I could. And here we had some residual right at the level of the filter. Did the angioplasty of the iliac vein. And I put a stent across the IVC filter. And this area was stented. This area with IVUS, it looked, you know, it didn't look like it was causing any obstruction. So I left it like that because of the fact that the outflow of the left iliac vein was on this area. The femoral veins had some thrombus in it, in this area, you can see, and I removed that thrombus out as well. So she comes in to me, you know, the pathology report was actually a benign malignancy, just a leiomyoma. So I put her on Coumadin. I discharged her on INR of 2. She was wearing compression stockings. Her right leg was pretty much normal. Her left leg was a lot less swollen, but still a little bit of swelling. And I scheduled her for a follow-up. And so anybody has a comment?
Well, first of all, when you spoke to her gynecologist, did you consider the fact that this was fibroid bleeding and whether or not she could be tried on some hormone therapy before even entertaining the idea of embolization of fibroids and to avoid a hysterectomy in a young woman? Was she given that option?
Yeah, we discussed that option with her. She's 45. She had 4 kids.
But there's a sort of a fear of giving hormone therapy to women who have DVT, but once you're on Coumadin therapy and anticoagulated, then that trumps the hormone replacement or the birth control pills, so they can actually be safely maintained on low-dose estrogen if that does help the endometrial bleeding.
I don't think we entertained that option, to be honest with you. So, you know, we did discuss different ones, and she decided to go ahead with the hysterectomy, and that's what we decided to do. Anybody else would have done anything different? You know, anybody in the audience would have treated the left side? Go ahead.
No, just my point was, if that IVC filter was so necessary that you had to put it, and then you went ahead and extended it and, you know, just nullified what you did previously.
You know, I didn't put it, and I don't think it was necessary at all, to be honest with you. And, you know, she could have been anticoagulated from the beginning. Maybe if I would have received her in the beginning, we would have treated her, the left iliac, and that was it. But, you know, she comes in and I don't know, would you have treated the thrombus in the iliac, in the left iliac, after 55 days with TPA?
Yes, yes. There's always an element of some acute thrombus, despite the fact. So calendar days does not necessarily mean you have to stop. Obviously, if it's a fresh thrombus, you'll have more success, but that does not impede you because it's just day 55. We've done these up to 1-2 years sometimes, and you get some benefit. And that benefit may be sufficient to relieve her symptoms.
Okay. Well, my plan with this lady is to see her in a few weeks, and depending on how symptomatic she is on the left side, then recanalize her left iliac veins, because her left femoral is really not thrombosed. Thank you.
Okay, well, we have 2 more presentations before our break. And if we have time, we may have a few questions, because I know my presentation is scheduled for 20 minutes, but it won't last that long. Dr. Ron Bush is going to come up and talk to us a little bit about the evolution of endothermal ablation. Ron kind of unknowingly has had a profound effect on my career. I told him earlier today that 13 years ago in 2001, I came to a course that he put on. I got a little flyer in the mail about the office-based treatment of varicose veins. And he really sort of put me on the leading edge of everything that's happened. And I went from doing 80% arterial surgery and 20% venous surgery to now doing 80% venous surgery and 20% arterial surgery. So, Ron, thank you.
Thank you, John. Thank you, panel. It's nice to be here in Chicago. I'm going to talk today about, where's the changer? Maybe, oh, here we go. Sorry. I'm going to talk today about comparing intravenous thermal ablation, current and future technology, and I hope you're comfortable in what you're doing because it's all wrong, okay? So we'll discuss why it's all wrong and why it's right, or why it doesn't make any difference what you're doing. So comparing modalities for ablation, we first must assume that the greater saphenous vein is the etiology of the problem. And we have to assume that failure to treat the greater saphenous vein is going to cause reoccurrence. So if we've established that, then we have to say the greater saphenous vein needs to be removed one way or another from the superficial venous circuit. So the mechanisms available today include heat, which is laser, steam, radio frequency, chemical, which is mechanical pharmacal or MOCA, Claravane, ultrasound-guided sclerotherapy, catheter-delivered sclerotherapy, surgery, high ligation stripping, or glue, Safion, which is the new expensive way that's been introduced. So thermal ablation with a laser, the mechanism of injuries by convective energy. There's 3 types of energy, except for atomic, which we don't use in the treatment of the science of the human body. There's either convective, conductive, or radiant. And convective energy is what occurs with laser, because once you turn the laser on inside the vein, you develop steam bubbles. Steam bubbles are 100 degrees centigrade. They hit the vein wall. They cause debridement. There's also some penetration of heat into the vein wall to cause eventual scarring, okay? All wavelengths are equal in producing steam bubbles. The only difference in the wavelengths are you just have to have less energy with a 1470 than you would an 810, because there's more hemoglobin absorption with an 810 and a 940 than there is with a 1470. Radio frequency, of course, is heat damage by conduction. The newer devices are now more effective than the older ones. However, the cost is higher than laser due to the current catheter that's used. Here's the histological results that we published back in 2008. This is 6 weeks post-ablation. You can see there's a clot present. And if I can get this pointer to work, which I don't, is it? Yeah. You can see right here, this is the 4 months post-ablation. This is a scar that's present inside the lumen. These are all fibroblast inflammatory cells in the muscle layer. So there is more going on than just affecting the endothelial cells. So that's why you get this contraction, and that more often than not, at about 4 months with heat, you don't find the vein present, which you will if you use sclerotherapy. However, it doesn't make any difference, which we're going to point out. Chemical ablation. Foam sclerotherapy may be delivered in multiple ways. The best results are by uniform application. There's rapid deactivation of foam in the blood, which has been proved by Parsi's studies. And on our blog, the Vein Experts blog, we have actually Parsi's thesis, PhD thesis on foam sclerotherapy published. He gave us permission. It's excellent. It's one of the best theses, one of the best writings I've ever seen on foam sclerotherapy, how it works, what's really going on. So I encourage you to read his thesis. This is the histology that occurs after sclerotherapy. This is liquid and foam. Over here is liquid. You can see there's no endothelial cells, okay? Nice smooth border. This is a subendothelial layer. This is a muscle layer. The adventitia, of course, is out. This is shows you there's some clot in the lumen, early clot. This is foam sclerotherapy. You can see there's great destruction of the subintimal layer and also into the muscle layer. It depends on the strength of the foam and the time of contact. But you can see there's a lot more damage with foam sclerotherapy. That's not the only reason foam sclerotherapy is successful, but it's one of the reasons. The other reason is because foam pushes blood out of the way, so you have less deactivation rapidly. Surgical, high ligation stripping. Reoccurrence is increased by standard flush ligation. If you do a ligation without flush ligation, it's better for the patient in the future as far as neovascularity. You can do high ligation stripping safely with tumescent. However, it's still usually being done under general or spinal anesthetic, which is really antiquated when you think about it. My daughter works for a vein clinic, and she actually used to work in same-day surgery, and the big venous specialist in town stood at high ligation stripping phlebectomy under general anesthetic, and there was obviously, after the procedure, a large amount of blood loss each patient they had. If you use tumescent, it's bloodless. This is an invagination stripping under tumescent. We described this Journal of the American College of Surgeons, 1999, 380 patients that had invagination stripping, ultrasound guided, no blood loss, no complications, easy to do, walk out of the office as soon as it's done. Saphion, don't know much about the long term yet. The 2-year occlusion rates in most reported cases, 92%. The cost, I think, is going to be very high. There's no long-term data or randomized trials. So what method should you use? Rasmussen, the British Journal of Surgery, stated that lasers are 94% effective in GSV ablations. This is at a 2-year follow-up. RF, 95%. Foam sclerotherapy, method not mentioned, was 84%. Stripping, 96%. The conclusion was all methods were equally effective, except a slight disadvantage with foam. This is from the Polish Medical Journal. You can't really read it, but all methods of laser ablation were the same. Okay? Long as you hit that target of about 60 joules per centimeter, they're all equally effective. Gillett published 2009 phlebology, 90% successful sclerosis of the saphenous vein in 271 patients. Complication rate was DVT, the medial gastroc vein, in 5 patients. I can assure you that we probably don't pick up medial gastroc vein thromboses when we do peripheral sclerotherapy on spiders, but it does occur. So it's not really out of the norm. There's the MOCA success rate's about 90%. That's a mechanical device, the Claravane. Kind of getting the thing, everything's about equal. The real determinant of success is the reoccurrence of veins that you treat. Except for flush ligation of the saphenous vein, the application of all these modalities have nothing to do with recurrence rates, excluding saphenous recannulization. And the primary result for saphenous recannulization is thigh perforators or untreated saphenous vein. This is in a Rivada study which we published this year. The primary cause of new reoccurrence, okay, without saphenous involvement, is either truncal insufficiency, AAGSV. 24% of all patients develop new truncal insufficiency, AAGSV, which corresponds to 24% of the patients developing neovascularity within the first 2 years after saphenous stripping and flush ligation. The main cause, though, is perforators, and you can't do anything about it. If you have superficial venous disease, you have the tendency, you have it regardless. And there's nothing you can do about it to prevent it. You just have to make sure your patient knows, I'm going to palliate what you have today, I'm not going to cure it. So final thoughts are that venous disease is not cured, only palliated. Now the following images I'm going to show you of what we do in Haiti. And if you have extra money and you don't want to give it to the government, go on the blog. There's some nice places you can give it in Haiti where the money will do better than it will do in the pockets of Washington. But what we do is treat patients for an average cost of $5, okay? As I'm going to show you the technique, you're going to get equal results with what you do today with your laser, your RF, your surgery, your stripping, whatever. The results are going to be equal. Here's what we use. The only thing that really costs anything is fiber vein. We use fiber vein from Europe, which is, of course, Sotradecol. It's a precursor to Sotradecol, and it's probably purer than the one you get in the United States, and it's cheaper. We use, as you can see right here, this is a, whoop, I'll go back here, sorry. Go ahead and get back here. These are right angle clamps. This is a catheter, a cannula we used to use for tumescent, has side ports. This is, of course, just a little phlebectomy hook. These are a couple syringes. This is a stopcock, 11 blade, an ace wrap, which we had to take our own ace wraps because they don't have them in Haiti. So that's the other expense. That's $3, and the fiber vein per unit dose is about 3 or 4. We use xylocaine with epi, and we dilute it. Here's the patient that we're doing. Oops. Okay, here's the patient. You can see he has multiple large varicosities, obvious saphenous insufficiency. So what we're teaching doctors in Haiti, healthcare providers, is how to do these without an ultrasound, okay? Now we have an ultrasound with us thanks to Terrasound, the new portable ultrasound. It's a it's I like the iPad ultrasound. I can't remember the name of it offhand. It's great, it's portable, it's lightweight, and you can use it about any place. It's really nice. This is what it looks like. This is the saphenous vein. So I'm showing the doctors this is what saphenous vein insufficiency looks like. So we go over the pathophysiology. And we take the ultrasound out of the room. We stand the patient up, palpate the saphenous vein, which you can always do in people that have saphenous insufficiency. Here you see we're about 2 inches below the groin, where the saphenous vein comes up over the adductor longus muscle. We doubly clamp it and divide it. This is a technique similar to what Stefano Ricci in Italy describes for echo-guided sclerotherapy, and it works great. So we divide the vein, we doubly ligate it, and then through the distal vein we pass this metal cannula because we can't afford to take disposable cannulas down there. Even if we had them, if I wasn't there, we couldn't use them, so I had to teach them how to do it without it. So this is a metal cannula we can get made for like $10, give it to them. They can use it over and over. On this cannula is 5 cc syringe filled with foam sclerotherapy, of course mixed with air since CO2 doesn't exist down there. We then oversew that vein, and then we do an exit phlebectomy. We find the first branch that's incompetent, we take it out. That unloads the system downstream. Patient's then wrapped. In follow-up, he can have foam sclerotherapy to any residual varices if they remain. The conclusion, it's easily learned, it's easily taught, it's safe. With minimal surgical skill, you can do this. It's a really helps the doctor, especially if you teach them how to palpate, because anybody that comes in with large veins in the medial aspect of the leg, if you can't palpate the saphenous vein at the junction, they probably don't have saphenous insufficiency. Okay? So these results, I think, will be remarkably similar to what we do with all of our results today. So far, the early results show there's complete occlusion, there's no reoccurrence, there's no complications. And it's, I think it's very adaptable for ambulatory venous clinics in the United States where patients don't have the money or the means to pay for all the expensive new stuff out there. Thank you.
Okay, so that's a little bit about the current and the future of what's going on. Thank you, Dr. Bush. Now I'm going to talk to you all, if you could put up my slides, about the management kind of varicose veins in association with vein ablation. So we're going to go to basically what I and what the majority of people in here who are going to soon be treating varicose veins might be doing. So your options for managing residual varicose veins when you're doing a saphenous vein ablation today consist of either doing a phlebectomy or sclerotherapy. If you're going to do a phlebectomy, you can do it concurrently at the time of the vein ablation, or you can do it in a staged fashion. There's not much written about sclerotherapy when done either concurrently or in a staged fashion, so most of my comments are going to deal with phlebectomy with a few on sclerotherapy at the end. The advantages of doing a concurrent phlebectomy at the time of your vein ablation is that you get a very rapid cosmetic improvement for the patients. You reduce their risk of a superficial thrombophlebitis in that when you ablate a great saphenous vein and leave large tributaries, they have stasis of flow and can develop an SVT, which can be quite painful. For me, it's sort of a competitive edge over all the vein clinics that surround me, where they have these patients come in for 6 or 8 sessions of sclerotherapy following their vein ablation. If you do phlebectomy at the same time, you can accomplish everything in one 45-minute to hour session that may take 6 to 8 sessions elsewhere, and you have happy patients. The disadvantages are, I do believe it's associated with increased peri-procedural pain and bruising. Your reimbursement is decreased because you only get paid 50% for a phlebectomy. You've added a 90-day global period to your procedure, and you also reduce your downstream revenue in that you won't be getting the revenue from future sclerotherapy. But at the end of the day, I think happy patients trumps all that. There are some, these aren't real contraindications, but there are some patients in whom I will not do a phlebectomy at the same time. If someone's on a major anticoagulant like a Pradaxa, Coumadin, Plavix, I generally will not. If a patient's had a previous superficial thrombophlebitis or extensive previous sclerotherapy, their varicosities tend to be fibrosed and stuck to the surrounding tissue, and they don't remove very easily. And lastly, if someone just has no cosmetic concerns and they're there for symptoms or venous ulceration, I don't do a phlebectomy on those patients. And this would be an example of a patient like that. You can see this woman with the X, that's before, and she had multiple episodes of superficial thrombophlebitis, and we were ablating her great saphenous vein to depressurize these varicosities. You can see the picture on the right is the after picture, and for her it was quite a successful result. She had no additional episodes of superficial thrombophlebitis. On the other hand, if she was a patient with cosmetic concerns, the picture on the right might not satisfy all of her needs. So I'm going to show you a few studies that look at the issue of whether or not to proceed with the phlebectomy at the same time. And this was a study of 155 limbs treated with radiofrequency, and by and large, the vast majority of patients were treated with a delayed phlebectomy or no phlebectomy at all. And you can see that roughly 30% of these patients required subsequent phlebectomy or sclerotherapy when they were treated with radiofrequency alone. 65% of the patients required no further treatment due to resolution of symptoms, not necessarily resolution of varicose veins. So in this study, 65% of patients required no additional therapy. This is another study that looked at radiofrequency without phlebectomy. They looked at 54 limbs, and after radiofrequency ablation, 13% of patients had complete resolution of their varicosities. And they actually went and counted the varicosities in the thighs and the varicosities in the calves to see how many of those actually resolved. And you can see the thigh varicosities resolved in 42% of patients, and the calf in 26% of patients. 41% of patients in this required no further therapy, and vein ablation alone was sufficient. This was a study of radiofrequency combined with phlebectomy, and in this case, 355 patients required or had concurrent phlebectomy, and 145 patients, or roughly 50% of the total, had a subsequent phlebectomy or a phlebectomy altogether. Of note, 83% of the limbs who had varicosities greater than 3 millimeters in size before their ablation, who did not have a concurrent phlebectomy, required a subsequent procedure. Here's a study looking at laser with concurrent phlebectomy, and they looked at 2,000 patients who had laser and phlebectomy, and they found that it markedly reduced the incidence of superficial thrombophlebitis. You will occasionally get a little bit of hyperpigmentation with phlebectomy, but it was quite minimal, and their postoperative pain was similar to EVLT. Most importantly, though, 87% of these patients were highly satisfied with the results from a cosmetic point of view. And then this is a small randomized study. I don't know that the statistics actually hold up too well, but they actually compared doing laser alone with laser and simultaneous phlebectomy. And you can see their venous clinical severity scores at 3 months were better in the group that had the ELVT combined with phlebectomy, but at 1 year the scores were equal. But more importantly, if you look at the bottom, if they just had an ELVT alone, 16 of the 24 patients required subsequent phlebectomy or sclerotherapy, whereas only 1 of the 25 patients treated with combined laser and phlebectomy required a subsequent phlebectomy. Now, Ron touched on this a little bit, and just when you think you have it all figured out, here's a man who looked at what happens if you just do a phlebectomy alone, what happens if you remove the runoff from this leaking saphenous vein. And he, in fact, studied 96 patients who were treated with phlebectomy alone, and remarkably, 50% of these patients had no great saphenous vein reflux at a year. So they were able to preserve their great saphenous vein. 16% of patients had symptom relief with persistence of saphenous vein reflux, and 34% of patients required a saphenous vein ablation at a year because of persistent symptoms or varicosities. So it's an interesting concept. When they looked at the independent predictors for reflux resolution, you can see if your reflux was a smaller segment, if your vein was smaller, or you started off with a lower venous clinical severity score, your saphenous vein reflux was likely to go away. Unfortunately, at least in Illinois, and for many of you that deal with insurance companies, we're not really allowed to tailor treatment like this, because with at least Blue Cross Blue Shield, if a patient has saphenous reflux, they won't cover any other procedure until you ablate that great saphenous vein. And so while there are many patients that I see where I know all I have to really do is some phlebectomies on them and they'll get all better, we really can't do that because of the insurance companies. And then as far as sclerotherapy of the future, this is probably a good study that I found. It was actually just published this month in the Venous and Lymphatic Disorder part of the Journal of Vascular Surgery. And they looked at 106 limbs treated with Claravane, or mechanical chemical endovenous ablation, or the so-called MOCA procedure. And this is a procedure where you use a catheter that has a little basket at the end of it that whips and injures the endothelium while simultaneously injecting sclerotherapy agents. And as you pull this back, some of the sclerotherapy solution inevitably leaks into the vein branches and will create a fibrosis of some of the venous tributaries of the great saphenous vein. And what they found in their case is, while it did not work as well as endothermal ablation, in that they had 88% of the veins occluded at 1 year as opposed to the 95 to 98%, only 22% of the patients they treated required adjunctive therapy at 1 year. So it may be that some type of ablation that allows the injuring agent to get into the branch varicosities, whether it's a Claravane procedure or maybe the new foam sclerotherapy agent Varithena, these may result in a reduced need for phlebectomy in the future. From my personal experience, I generally find that when I can ablate across a branch leading to the patient's varicosities or side branches of the saphenous or greater small saphenous vein, generally you'll see significant reduction in the branch varicosity size. When you're ablating and leaving end branches, such as treating the anterior accessory branch or perforators, you tend not to see nearly as much regression. And this is supported by a study from the Journal of Vascular Surgery from 2008, where they treated half their patients with just saphenous vein ablation at the thigh versus the other half where they had saphenous vein ablation starting in the mid-calf. And the bottom line is a longer segment of saphenous vein you treat, the more resolution you have of varicosities without the need for phlebectomy. And this is just an example you never quite know, but on the left is a gentleman with extensive varicosities, and I ablated this great saphenous vein from just above the ankle to the groin, and I used all my tumescent anesthesia, so I didn't have any left to do the phlebectomies that I normally would have done. He came back to the office for his follow-up visit 6 weeks later, and remarkably, his leg had, all the varicosities in his leg had resolved. How do you decide what to do with these patients? Well, I think at the end of the day, first of all, you have to know what's the patient's problem and what's the result that they expect. Do they have pain and they want their pain to go away? Do they have pain and cosmetic concerns? If they just have pain, then probably you just need to do a saphenous vein ablation. You have to look at the results you're getting with the therapy that you do. Are patients getting good cosmetic results? Or are they getting good symptomatic relief? You have to look at your own experience and skill set. But as we're going to talk about in the next session, I think everyone can learn to do a phlebectomy, and I do think it's an integral part of a successful vein practice. And then you have to factor in the clinical studies that demonstrate the results that other people are getting. This would just be another example of a patient with a venous ulcer and extensive varicosities. In this patient, he didn't care about the cosmetics. We ablated his great saphenous vein, and 6 weeks later, his venous ulcers healed, and his saphenous varicosities are also improved, but they're clearly not completely resolved. So in conclusion, combination vein ablation with phlebectomy reduces the need for subsequent procedures in patients with saphenous vein reflux. There really aren't any studies comparing phlebectomy with sclerotherapy for treatment of residual varicosities. And I think some of the newer tumescent-free procedures may reduce the need for subsequent intervention, but clearly further studies are necessary. Thank you very much. Now,
yes, thank you. I'll make this toward the end of the afternoon as quick as possible. This is a very interesting case. I'm going to ask some of our panelists to help out here. We have a 73-year-old otherwise healthy man with history of right total knee arthroplasty approximately 6 months before. This was a very, very interesting gentleman. He was doing, despite his age, skydiving, scuba diving, and had some familiarity with alcohol. So in one of these events, this is, by the way, not anterior tibial vein, he was using an all-terrain vehicle. And what happens is that using the alcohol and being on sand dunes, he hits his right knee toward the front of the ATV, and there's a metal plate behind where he's sitting. So the knee moves forward and then backwards and hits this metal plate. And then he comes to the hospital with very progressive right lower extremity edema, pain, and induration. I was contacted after 1.5 days. By 30 hours, the limb size was twice as large on the right side as the left side, but he had very good pulses. Now, I'm going to ask Dr. Zierler to have a look at this. I know this is not the best ultrasound, but this is the venous duplex. This is the popliteal area. And you see lots of edema. This is without compression, and this is with compression. Do you want me to go forward and show you the longitudinal views too?
Oh, sure.
It's okay. I'll do that too. And then here is the distal femoral vein. This is like partial filling here. And then move along to the longitudinal view. Not much here. This is the distal femoral and the popliteal vein. So what's your thoughts about this?
Well, there's obviously lots of swelling, and I don't know if that's just sort of blunt trauma, or if there's actual hematoma in there, or there's been some rupture, and in spite of even with intact pulses, he still could have an arterial injury. So we haven't totally eliminated that, although if his ABIs were okay, that would be somewhat reassuring. But I mean, I think there's at least partial occlusion of the vein based on the color flow and I couldn't really tell about the compressions very well. But again, it's not clear whether this is extrinsic compression or intrinsic thrombus at this point.
Right. Well, thank you. That's correct. And the radiologist read that as partial occlusion of the distal, partial DVT of the distal femoral vein and popliteal vein. But you've seen these patients. This was very much disproportionate to the physical findings were disproportionately worse than the venous duplex result. So with that, and he had not responded to the anticoagulation. In fact, he had become worse. So once I got consulted, I took him to the lab, and this is the initial picture. I exposed the popliteal vein under ultrasound guidance. I saw a very big vessel. I said, this is a slam dunk. We're going to go in and take care of it. This is DVT. And the injection, you can see this sinusoid structure here, this mini lake of contrast. And really the flow up north is, you can see it up here, but really nothing here. So what we did next is we went into this time to the posterior tibial vein. Under ultrasound, I cannulated that, and you can see the flow comes here, and it stops. And then reconstitutes up there, and there is this sinusoid structure full of blood or contrast there. So this patient had actually confused his popliteal vein, and it was like smashed because of this trauma. Now on the shelf, so what we decided what to do now. We don't have flow in the popliteal territory. We only had a few stents at that time. We had 2 Viabond stents, which are self-expandable, and we had 1 ICAS atrium stent, which is balloon expandable. So we went ahead, and this is a 6 by 10 initially, followed by a 6 by 5 Viabond stents here, and we still needed some more territory. So the only stent left was an ICAS atrium, which you're not supposed to do because it's a balloon expandable stent, and this is in a rough territory. It's right at the in the popliteal fossa. But at any rate, these 2 indentations happened during the procedure, but we went ahead and deployed that, and then flow is restored. He did really well, and this is the appearance of the stents, 3 stents placed there. Within several hours, he had appreciable improvement. He was placed on dabigatran at that time and low-dose aspirin. And a week later in the office, his leg was back to his normal size. So this shows the successful treatment of the contusion of the popliteal vein with covered stent through a mid-posterior tibial vein access. And this is a follow-up venous duplex 24 months, 2 years later. You can actually see the indentations that I showed you in the ICAS stents right here, but flow is maintained, and this was really a remarkable result. So in summary, continuation of the popliteal vein is a very rare entity. It's due to blunt trauma in the presence of orthopedic hardware. It rapidly progresses, and it's highly responsive to covered stenting. That's it. Thank you.
Motion. I've got a 100% failure of covered stents over the years, so I stopped using them. And if it was just a contusion, why don't you keep them anticoagulated and let it recover? After a couple weeks, then you might not have needed a stent.
Well, I think, I have to just refer you back to your initial comment. If you have inflow and outflow is preserved, you get good results. Doesn't matter which territory it is. I think the reason you didn't have good results is because you probably were dealing with DVT cases, you have venous sclerosis, venofibrosis, and your inflow was impaired. And no matter what you put, covered or non-covered, you're not going to get a good result. And in this particular case, he was worsening in front of our eyes. We could have waited for another, few days, but seeing what I saw, I thought it's in best interest to see invasively what's going on.
Will you keep him on anticoagulation indefinitely now?
Yeah, he's on, we kept him on anticoagulation for dabigatran for 6 months. After that, we went to just aspirin indefinitely.
Should we do questions or should we take a break? Okay. Does anyone out there have any questions?
Hi, I'd just like to ask a question. In view of our concern about valves and post-thrombotic syndrome, how do you see Xarelto fitting in the treatment of acute DVT, especially with the drug being promoted essentially an outpatient treatment of DVT?
Yeah, well, we now have very good data about the success of new oral anticoagulants. Xarelto has been actually approved for this indication in the US. Dabigatran recently got approved too. But you have to know that both the trials that did these, they used parenteral anticoagulation prior to that. With dabigatran, you have to have 5 days of prior anticoagulation. In the Einstein DVT trial, it was 1 to 2 days of parenteral anticoagulation before going to Xarelto. In my practice, I uniformly use new oral anticoagulants, now apixaban and Xarelto. Since I'm using modified dose of thrombolysis, I immediately switch them after 2 hours to new oral anticoagulants, and they are out the door in less than 2 days. I also keep them on low-dose aspirin for at least a month.
Microphone number 4. Question for Dr. Golan. You did mention that the typical insurance approval these days is if you have an incompetent greater saphenous, you have to treat that before you can do anything else. I was curious how you get the insurance company to approve a concomitant phlebectomy, because I've been out of this for a while, but when I was doing it, you had to see the patient back at 3 months and document that they still had symptoms or still had varicosity before you could do something else.
Well, you know, it varies by insurance company and it varies by region. In Illinois, for a period of time, Blue Cross had a policy that they would only cover a vein ablation, and then you had to wait an additional 6 weeks, and if the patients were still symptomatic, you could bring them back for subsequent phlebectomy or sclerotherapy. Back in those days, I told the patient the policy, I told them what I thought was the best treatment, and I told them they could pay cash for the phlebectomy at the same time, and so that's how we managed that situation. We had the patients pay cash, and if they didn't want to do that, then they would go through the routine of waiting the additional 6 to 12 weeks prior to proceeding with additional therapy.
I have a few questions. First of all, both on the arterial side and venous side, for decades, just haven't crossed joints. Now, it seems like everyone doesn't mind crossing the popliteal fossa or the groin area with their self-expanding stents. Is that your opinion? Doesn't bother you? You don't see stent fractures?
I'll tell you what the official guidelines is, and I'll tell you what I do. The official guidelines is below, you can do iliofemoral stenting, meaning that your proportion of your iliac stent extends into the common femoral vein. If you look at the Society for Vascular Surgery, American Venous Forum, they specifically say in the popliteal femoral vein, you're not supposed to use that because of high stent thrombosis. But in cases the cases that I've showed you, or in cases we have just a focal lesion, I've used it. And if there is good inflow, good outflow, your restenosis risk and thrombosis risk is similar to the iliac. If you don't have good inflow, good outflow, which is the usual case, you probably are looking at 100% restenosis.
You know, I think that we always try to avoid stenting across joints, but I will say I think there's a pretty good literature in interventional radiology in particular regarding venous stents going across the inguinal ligament, that they actually work remarkably well and are indicated.
Okay. Patricia, you didn't do a thrombectomy on that case of that lady, the last pictures that you showed. What reason was that?
Well, the thrombus was about 6 months old, the most acute episode, and her original DVT was in 1979. So thrombectomy devices don't work very well on chronic DVT. I mean, they just don't even turn. The angiojet doesn't do too much, and the trellis doesn't even rotate. So it's not really, hasn't been. Now there are people who are doing trials with angiojet and ECOS on chronic DVT, and Dr. Ossie might speak to that. So there's some, but I haven't seen a lot of change, and I get good results with the drip. And I agree with Dr. Sharifi that low-dose TPA is almost as effective as what we've been using as a regular dose. So a half a milligram per hour and 100 ml of saline will do almost the same amount as double that amount, so it gives you a safety margin.
It's because of the problem with ICU patients staying for a longer time. We decided to start using the angiojet in chronic DVTs just on the iliac and from the common femoral to the IVC area. And for those patients with IVC obstructions, what we saw is that we could cross the occlusion in an easier way after using the angiojet. But I agree with Patty that it's only in selective cases that you just have real problems to cross that, and you keep those patients under TPA for 24 hours and you just can't go over. We try the angiojet, and sometimes the angiojet just gives you the signs that you have to take your catheter and your guide wire to cross that occlusion and go further.
One last question. Do you always put in filter wires prior to your venous interventions?
IVC filters, you mean?
Sorry, IVC filter.
You know, can I make a comment before we continue to the next question? You know, when you look at chronic thrombus histologically, it's just scar tissue, it's fibrotic tissue. So I think that maybe what the angiojet does is by mechanical pressure, it might create a bigger channel. But you know, like he said previously, that sometimes it's not just chronic thrombus, that you also have some acute developing ongoing thing that you might be able to resolve. So
the reason why is because when I started to learn how to do those chronic obstructions, recanalizations, we learned that you start with TPA. So if what you are telling is true, there is no reason to use lytic therapy in a scar tissue to get rid, the way to get through. But what we saw is that sometimes that you have that clot that is chronic sitting there, and the angiojet helps you to just pull them out and find a way to cross. And answering the filter, we have done, I don't know how many patients now for recanalization, and I don't remember implanting an IVC filter prior to do the recanalization, because even for acute, because what we do is that you're infusing lytic therapy and heparin, and that lytic medication is just going all the way everywhere, and what we do believe is that you're protecting those patients from pulmonary embolism with that amount of lytic medication going through it. So I'm telling you, we never had any pulmonary embolism doing this kind of procedure.
I actually concur with you. You know, we did a study on this called the Filter PEBI trial, published last year. We used to do filters in almost everybody in the torpedo trial, but you're now doing it less than 10%. If you are just doing catheter-directed thrombolysis, there's no necessity for putting a filter. If it is really acute, patient has had risk factors for iatrogenic pulmonary embolism, you won't change mortality, but there's about 4% chance that in the lab you will have some excitement. The patients may become hypoxemic. So you have to choose and select your patients. To answer your questions, probably less than 10% of all comers may benefit.
Okay. Go ahead.
So I just want to say that I don't think that saying that nothing goes up, it's completely accurate, because we really do not know that, because we don't do CTA on everybody after the intervention. But what we need to think is that they don't become symptomatic. And it's rarely that you have somebody that becomes symptomatic. In fact, I think that if you use a lot of TPA, I think that TPA has an inflammatory response syndrome that I know some of these people that you see and they have massive thrombus after thrombolysis, you see how they drop their urine output, they get swollen, the creatinine comes up, and you say, well, I didn't use that much contrast material, and then they might become a little bit hypoxemic, and then you do a CTA, you see no PE. So I sometimes you need, I'm pretty sure that when you lyse a massive amount of thrombus, that you actually incite a certain amount of systemic inflammatory response that will give you all these things without necessarily being an embolus or anything like it. So I don't think we need to put a filter on everybody.
Okay, well, our time is up for this session. We're going to take about a 20-minute break, and then we're going to reconvene at 3:30. Thank you all.
Good seeing you.
Yeah, thanks.